I'm Dr. Michael Klouda. I've actually been here at ETMC and in Tyler, Texas for the last 16 years. This talk is Genetics 101, what I'd hope you would know, and I'm going to try to shoot you through medical school here with a little bit of knowledge in genetics and mutations and what have you, and why these are important and what we're doing and what we're addressing with breast cancer and then ovarian cancer and actually some other cancers. But since I'm with the Breast Care Center, I'm going to try to focus on the breast and ovarian cancer end of things. When we start talking about breast cancer risk, we are looking at a situation where we have the vast majority of women that are diagnosed with breast cancer fall into this sporadic pool. And that is, these are cancers that occur for reasons we don't know, but they may be the only cancer that develops in that family. There's another percent of cancer that we find has a familial component. There's one or two individuals that are diagnosed with breast or ovarian cancer, and that you know that breast cancer runs in your family, say. And then we look at a family that has a hereditary mutation, and you can see that we get up over 87% or so of these individuals that have a hereditary mutation can ultimately develop breast cancer. So we're looking at cancer risk levels, which I just said, sporadic, a low lifetime risk. These cancers occur by chance, 8 to 10%. Familial cancers caused by a combination of genetic and environmental risk factors, 15 to 40%. And then if you have the hereditary or a mutation in the family, a very high lifetime risk, up to 87%. So why does that occur? Well, these are cancers due to a mutation when a gene is not normal. And it's passed down through the generations from parent to child. And it's not a one-to-one transmission. It's actually, you got a 1 in 2 chance. It's a 50-50 proposition of catching that gene from your parent that has the gene. And it may develop one or more cancers, and these occur often at a much earlier age. A breast cancer, say, in her late 20s, in her early 30s, as opposed to the 50s or 60s or 70s. Well, I've mentioned a mutation. What exactly are we talking about with the mutation? Well, this up here is a normal individual, and a normal individual happens to have 2 normal genes. And over the course of their lifetime, for whatever reason, we don't say this is breast cancer, we don't understand exactly the insult that occurs to cause that mutation, but one of these genes is damaged at some point in their life. However, you still have a normal gene, and this normal gene still produces a protein that goes about repairing DNA damage as it finds it, and they're okay. Until some other insult comes along and damages the other gene that was formerly normal, and now we get into a situation where a tumor can develop. If you have a hereditary cancer or a genetic mutation, you start out already with this damaged gene. And that's why something that occurs in the environment causing the genetic damage, now you have 2 damaged genes already. So you can see where this might have occurred in this woman's 30s or 40s, and she's fine. If that happens to the same woman with the genetic mutation, she's already in trouble, and a tumor can develop earlier. What about the risk for patients with BRCA mutations? Well, in the general population, breast cancer has about an 8% incidence, whereas in a BRCA mutation, they can, over the lifetime, up to 87% of those women can develop breast cancer. Ovarian cancer is very rare, by and large, less than 1% of the population. If the mutation is present, up to 44% of those women can develop ovarian cancer. Male breast cancer is not impossible or not unheard of. It's very, very rare, but if there's a mutation, up to 8% of those men that carry that mutation can develop male breast cancer. And on down the line here, a secondary breast cancer after they've had their first one, only 11% of women without the mutation, but that happens up to 6 out of 10. Pancreatic cancers and then prostate cancers are also elevated in the same way. So knowing your risk can guide what your doctor can do to help manage you. And that's our whole goal of doing this, what we're doing at the Breast Care Center, trying to identify women that meet certain criteria to screen or evaluate for perhaps a genetic mutation. So if we can find a breast cancer at an earlier age, they have a better prognosis. We know that through our screening data. The smaller the tumor, the better the prognosis. And what about this, preventing cancer altogether? If we're able to find a woman who we know has an almost 8 out of 10 lifetime chance to develop breast cancer in her 40s and say, hey, you might want to consider addressing this now before cancer develops, we can make a big difference in that individual's life. How do we do that? Well, we evaluate each patient's family history, and we look at their hormonal history, i.e. when they started their first period, when they became menopausal, how old were they? How old were they when they had their first child born? And then we look at your overall family pattern. That's all mapped out. And then we determine whether or not you meet criteria for testing. So we don't want to test people that have almost no chance of having a genetic mutation based on their family history. We're looking for a certain pattern, and we'll look at that. So once we find that certain pattern, and we test them and say they come back positive, well, what can we do? Well, we can tailor their management moving forward. We can make certain recommendations for increased surveillance with mammography and even breast MRI. We can talk to them about drugs they can take to lower their risk. That's called chemoprevention. And of course, there are surgeries that are recommended and are certainly optional for some women to consider, and that these are called prophylactic surgeries. Specifically, say, removal of the breasts or ovaries before that cancer has a chance to develop. So what are we looking for with the criteria in a family history? We're looking for 3 big things. We're looking for cancer at a young age. We're looking for multiple cancers and rare cancers. So what about young age? 50 years. Breast cancer onset before the age at or younger than 50 years. We're looking for multiple cancers, multiple breast cancers on the same side of the family, a prostate, a pancreatic, or any combination of those 3. And then we're looking for the rare cancers. And these are ones that develop at any age. And with the women, that's any history of ovarian cancer in the family is very important to know about. Male breast cancer, second primary breast cancer in both breasts, which we term bilateral breast cancer, and then triple negative breast cancer. And you may or may not have heard about that, but that's a certain type of breast cancer where it does not have these hormonal receptors, estrogen and progesterone receptors on the tumor cells of the cancer, and they don't express another protein called the HER2/neu protein, which if that was present, you'd be treated with Herceptin. But if it's not there and all 3 are absent, that's triple negative cancer. It's relatively rare, and it's something that's common or more common in a genetic mutation type cancer. So let's say we go through your family history and we determine that you meet criteria for genetic testing. You're then counseled as to what this test entails, what we hope to learn from it, and we then, if you agree to undergo the test, we use a kit. Now, in the breast center, that is called the buccal specimen collection. We used to use this one here. I don't know if you can read this, but it says blood draw kit. That you used to require a blood test to do a genetic test on an individual, but now we just collect actually saliva or spit, for lack of a better term, in a special collection vessel, and that is a vessel that looks just like this. Here's one of the kits I've opened up, and this shows the a tube, if you will, and there's this a little bit wider up top to collect the saliva. This has a preservative agent inside of it that's snapped over, and it activates and preserves the specimen before we ship it off in this transport case here. And there is a brochure right here, which is a very concise yet informative brochure for patients explaining all of this they've just been counseled on. And of course, we have some paperwork that we need to fill out. Here's just an example of a gal undergoing the genetic collection where she has to sit and collect some saliva to a certain level in that tube, and then it's capped off and sent on. Now, here's the paperwork form. You can see it's quite detailed because to satisfy those individuals that are paying for these tests, the insurance companies by and large, they want to know that the patient actually meets a certain criteria. And we use an NCCN criteria, which is the National Cancer Center Network. And that is a national standard that we make sure the patients meet, and that's all detailed on this form. And this is sent off with the specimen in a special box and mailed off by FedEx. And they go off to the company in Utah where they're analyzed, and that takes about 4 to 6 weeks. And we get a result back. And the result's either negative or positive. And we'll talk about the implications of that. So the result is negative. It comes back and it states that there's no known mutation present. Now you see this is in bold letters. Why do I say known? Well, every year we're learning more and more with all this genetic information that is collected. And they're able to determine whether or not a mutation exists that they are certain is associated with some of these different tumors. Well, that's good to know. If that's positive, then we know that that's a good real result we can act on. But sometimes you get back a positive result that is of a VUS, a variation of unknown significance. That means there's something they've identified, but it's not correlated with anything that you want to act on right now. It does not have any specific recommendation associated with it, and they are just keeping track of all those based on your family history and these different mutations. But what about a positive gene mutation being present? And that's called a deleterious mutation, meaning that's a mutation that we know about. It's present in you're the patient that sent this in. This is present in your family, and this specific mutation is associated, maybe it's called the BRCA1 mutation, where we know it has an increased risk to develop breast and ovarian cancer. So we can counsel that individual that over the course of your lifetime, from age, say, 32 on, you've got almost, say, a 7 out of 10 chance of developing breast cancer and maybe a 3 out of 10 or to a 4 out of 10 chance of developing ovarian cancer, and there's something we can do about that. And here's what we then get into. We talk about management. So let's say the patient's result comes back negative. So the risk is decreased, but it's not zero. There's always a baseline risk in the general population to develop breast cancer. Like we said earlier, it's about 8% to 10%. If there's a strong family history in the family and you're tested and there's no mutation present, it means you may still have a risk that's elevated based on your family history, but it's not up at the 7 out of 10 range, 8 out of 10 range. It's elevated but not that high. If it's positive, we then counsel these patients on, these are your options. Surveillance, which means checking, usually more frequently or with a more sensitive test, and we'll talk about that. Chemoprevention, which is administering certain drugs such as tamoxifen or raloxifene. Prophylactic surgeries, removal of the breasts, certainly removal of the ovaries and fallopian tubes. And then, of course, there's do nothing. Some women, I'm sure, learn that they have a genetic mutation and they decide to just let things be and do nothing. I don't really recommend that, but that's certainly an option. So how do we undergo surveillance if we have a known mutation? Well, mammograms, I said start early. Let's say that gal got tested and she was only 29 in her family, learning of her family history. She gets the test, it comes back positive. She decides she doesn't want any surgery, but we're going to start early with surveillance. We start her mammograms annually. We also start annual contrast-enhanced breast MRI exam, and that's inside the magnet. They administer some contrast. We're able to look at both breasts very carefully and assess whether or not there's anything that enhances or, quote, lights up to suggest there might be some disease present. And then, of course, we encourage diligent self-exam monthly. Every woman, whether you have a mutation or not, it's my opinion, should learn what her breasts feel like and be checking them monthly. Full disclosure, my wife found her own breast cancer on self-exam. It was not apparent on the mammogram, even knowing where it was. We couldn't see it on the mammogram, but she found it because she checked her breasts. And then ovarian cancer, and you can see I have a question mark here. Why is that? Because it's extremely difficult to do good surveillance for ovarian cancer. It's hard to detect. Some of the things they've offered, transvaginal ultrasound, that's an ultrasound examination that's done through the vagina, looking at the ovaries in the body and trying to determine whether or not they appear normal or abnormal. A CA-125, that's a chemical that circulates in the blood that can be measured. We know it's elevated in ovarian cancer. Problem is, it's elevated in a lot of other things that have nothing to do with ovarian cancer. So it's not very specific. A pelvic examination, it's not worth a whole lot, but it certainly could be done. And so you're left with a bit of a quandary with how do we surveil for ovarian cancer? Well, we don't really recommend that. With ovaries and a positive BRCA mutation, we recommend they consider the total abdominal hysterectomy and a bilateral salpingo-oophorectomy. And those are big doctor words that mean take the uterus out, the ovaries and the tubes completely, and then you've eliminated almost to zero the risk to develop ovarian cancer. Risk decreased by 96% in a BRCA positive individual if you do that surgery. But let's say it's that 29-year-old gal again, and she's married, she's got one child, she's planning on a couple more. What does she do? Well, you don't state, nope, you got to stop and take all your ovary and tubes out. You let them complete their family. And once the family's complete, then she can consider that prophylactic surgery. And again, let's say she completes her family at 35. Well, now she's going to have her ovaries out, but she's essentially menopausal. They've removed the ovaries completely. You've thrown a 35-year-old gal into menopause, and that's not healthy. That has its own associated risks. So what can you do? Well, they can then start safely estrogen replacement therapy up to age 50 or so, when they would naturally become menopausal around there. What about chemoprevention? Is there anything you can take to help reduce the risk of ovarian cancer? We know oral contraceptives, birth control pills, do a very good job of reducing the risk, up to 60% risk reduction reported in BRCA mutation carriers. As far as breast cancer risk, there's some contradictory evidence about it. Some studies showed it elevated the risk, others showed it was protective. I would think it's probably protective, because the evidence showing it was raising the risk were those done back in the early 70s, where the dose in the oral contraceptive pill was much higher in hormone than it is now. We use much less for this now. And again, oral contraceptive use for contraception, stopping pregnancies, is acceptable in these women. What about chemoprevention for breast cancer? Say she opts, I don't want a prophylactic surgery, but I will consider taking a drug to reduce my risk to develop breast cancer. Well, we know that in BRCA carriers, positive women with BRCA mutation, 53% decrease in developing another cancer if they've had one diagnosed, one study showed. And then unaffected BRCA2 mutation carriers, there's almost a 6 in 10 decrease, 62%. An unaffected high-risk individual, so they don't have the mutation, but they got a bad family history, they're concerned about developing breast cancer, they're at high risk, they take tamoxifen over 5 years, 45% decrease. So we know tamoxifen is an effective drug to reduce development of breast cancer. However, there's no free lunch. Tamoxifen itself has some side effects, and they can be significant. Raloxifene is a drug very similar to tamoxifen, and it's grouped here with the aromatase inhibitors. These are another class of drugs that are similar to tamoxifen. They work slightly differently, but they're essentially anti-estrogen drugs. They believe that it will decrease the risk in postmenopausal high-risk women, but we don't have any data yet on the aromatase inhibitors in BRCA-positive women that are postmenopausal. Now, some people say, I probably should have the genetic testing, but I'm really afraid that if I do that and I'm positive, I'll never, ever get health insurance again in my life. Nobody will insure me, or nobody will employ me because they don't want to run the risk that I'd get sick. Well, that's actually a bit of a myth. There are federal and state laws that prohibit genetic discrimination against any individual who's had genetic testing and found to have it positive for a mutation. In 2008, and enacted in 2009, but in 2008, President George Bush signed in a law. It's called the GINA, Genetic Information Non-Discrimination Act, GINA, and that federally codified, protecting individual patients that have had a positive test, that group plans and individual health plans cannot refuse to insure them just because of that genetic mutation. This also prevents employers from using or accessing that genetic testing information. And this really tries to take this whole issue of discrimination or losing your insurance off the table. It's no longer possible that they can do that. It'd essentially be against the law. Now, we've had over 500,000, 500,000 clinical tests have been performed, screening individuals for genetic mutation in this country. We don't have any documented cases of any discrimination thus far. So, what can you do about all this? Well, certainly you want to know your family history, know the relationship of those individuals that have had cancer, and especially how old was that person? How old was Aunt Mildred when she had ovarian cancer? Communicate with your family history regularly with your clinicians. As you are going along and you have your annual visit with your doctor, You may have learned since last time that so-and-so developed an ovarian cancer, or breast cancer, a pancreatic cancer. Update your doctor. Let them know so you can have a concise, complete medical history. Now, this is interesting. At family gatherings, use that as a way to find out more about your family history. Some people may think that's an odd subject to broach, but it could save your life. You may learn something that is very significant that would prompt you to say, hey, you know, I probably ought to look into maybe this is something I need to be tested for. And then educate the community, friends, and family about the importance of your family history. Again, that's exactly what we're talking about. We can make a difference in being able to ultimately personalize our health care. And if you need extra surveillance, you need to learn whether or not you need the extra surveillance, and then go about getting it. If you think you're at risk for genetic mutation, you can certainly ask or inquire with your doctor about testing. Thank you very much for your attention.